Morning. This meeting is being recorded. Um, we are going I'm so happy to be here to talk with you, to see some of you again, and some of you for the first time, to talk with you a little bit about one of my favorite topics, which is latch and positioning. And I bet you it's it's one of your favorite topics as well, or it's one of your least favorite topics, because it's one of those things that if you work with breast or chest feeding parents, this will come across your desk over and over and over and over again. I would say in my practice, if I'm going to guess, it was going to be probably 80% of people who I see present with some issue with latch and positioning. And I bet it's the same for you too. And so what we wanted to do today was design something where we could get a little better idea of our basic skills. These are really the most important when it comes to latch and positioning. And then additionally, on top of it, like what makes latch and positioning even important? What makes it possible? How can we better understand that so that we can better inform, educate, refer out, etc. So I want to start initially, actually, I'm going to go ahead and stop my share here because what I want to do is I want to actually start out initially with just getting a baseline of your knowledge. So I know many of you are lactation educators. I know almost all of you work already in lactation and basic lactation management skills. So I'm looking for a volunteer, somebody who doesn't mind speaking on Thursday morning at 8 o'clock, 9 o'clock, whatever time it is. Can I get a volunteer from somebody? I promise it won't be too bad.
I can share.
Yay, thank you, Yuli. I appreciate it. And it is Yuli, right?
Yes.
Okay. All right. So Yuli, you and I are going to act out a scenario. I'm going to be your client. Let me look up how old my baby is here. So I have a 12-hour-old infant, and my baby was born at 39 weeks and 4 days. Okay, my baby's 7 pounds and 7 ounces. I am 29 years old. This is my second pregnancy, but it's my first live birth. Okay, I was induced, so my birth was quite long. And when I come to you, I'm having really, really severe nipple pain. And in kind of 5 minutes or less, I'd like for us to kind of work through that. So do you mind role playing it with me a little bit?
Okay.
Okay.
Let me try and remember everything you said about the history.
I know, right? I just threw it right on you. Okay, you want me to tell you again?
No, it's okay.
Okay.
I'll ask the rest of the participants for support if I miss something.
Good call. All right, go ahead.
Okay. So, hi, Hannah. How are you?
I'm good, thank you.
Congratulations on the birth of your baby. How are you feeling?
I'm okay. I'm tired, and mostly I'm just in like a lot of pain.
Okay. So tell me more about your pain.
It's like when the baby eats, like like the nipple, it just hurts really badly.
Okay, and what are you noticing? What are you noticing in your nipples?
It's just like when the baby latches on, it's just like razor blades. Like I'm actually thinking about like not doing it anymore. It just hurts so badly.
Okay, and can you share a little bit of how you're positioning the baby when you're getting ready for him to latch on?
Sure. Do you want me to like just show you?
Are you comfortable with that?
Yeah, I can. Yeah, I can show you. That's fine. Okay, so what I do when he goes, like he's hungry right now, and he's like crazy when he's hungry. So it's just like, if I hold him, I just hold him like this, and then he just latches on. Ow, ow, ow.
Okay, I can see, yeah, and I see it on your face, the pain that you're experiencing. That must be really hard because you're trying to breastfeed, right?
Yep.
And you're experiencing pain.
Yeah.
Okay, so what is your goal with us meeting today? What would you like to accomplish?
Well, I mean, I know the baby's got to eat, but like this just really hurts. Like it just really hurts. And I just don't know if I can keep going. I mean, I wanted to breastfeed, but I don't know if I can keep doing this.
Okay, are you open to me showing you some different positions? Or
Yes, please. Like, can I take him off now?
Yes, go ahead and take him off. And do you know how to take him off? Oh, you beat me to it. Okay, so are you aware of the different ways that you can latch the baby off your breast? I saw right now that you pulled him out.
Yeah, isn't that the way they come off?
Okay, so that may cause some pain, which I did see right now.
Okay.
Do you want to go into the different techniques or?
Yeah, do it. Let's do it, Yuli. We got
All
like
right.
2 more minutes.
Okay,
Help
so
me fix this latch.
something that you can do is to use your pinky to help the latch. How do you say it? How do to not
Bring
this?
the heel. You got it.
Yeah, to take the baby off the nipple. So you can use your pinky, gently put it in the baby's mouth and help to remove the baby from the nipple. And instead of pulling the baby off, because that also stretches your nipple and causes pain.
But what about when he goes on? Because it just hurts. Like from the moment he goes on, it's just painful. It hurts.
Okay, so we're going to talk about the baby's mouth opening, how wide it has to open, the angle as well of the baby. So I can support you with those different things to help ease the pain and the discomfort that you're feeling.
Okay. Let's do that.
Okay.
You ready to be done? Let's
Yes,
go.
I'm like, do you want to keep going?
Do it. Come on, let's go. Fix me. Fix this baby.
Fix you.
I'm ready to give up. You're doing great.
All right, so let's start again by positioning the baby to a position that you're comfortable.
Okay, so I'm just gonna hold them like.
Okay, so don't latch the baby on yet.
Okay.
Okay, are you able to put the camera a little bit closer so I can see, like a little over? Okay.
Is that helpful?
Good. Yes, that's helpful. So is the baby facing you, your chest?
Okay, so like that.
Mm-hmm.
Wait.
Okay. So is the baby already looking? Do you see, is the baby looking for your nipple?
Oh yeah, like crazy.
Yes. Okay. So what you can try is hold with your left hand, try and hold your breast.
So with this hand I'm gonna hold.
Because let's see, which one is it for you? How are you holding the baby?
I don't know, like that.
It's backwards, right? The way I'm seeing it.
Yeah.
You're looking at the camera.
Yeah.
So if I'm holding the baby here, your left hand. Is this
Okay.
holding the baby?
It's my right
I'm trying to
hand.
mirror my view
mean.
with yours. Okay.
Okay.
Your right hand.
Mm-hmm.
Yes.
This is my right hand.
Okay, that's your right hand. Okay, so with your right hand, with your free hand, try and hold your nipple to your breast to try and help the position of the baby's. There you go. Okay, that's better because I can't see.
Yeah. Okay.
Okay, and now, okay, with the baby, is the baby opening his mouth?
Yeah.
Is it a wide opening, noticing, or is it a small?
Yeah, I guess it looks wide. It looks kind
Okay.
of wide. Oh my gosh, she's trying to get on, but it hurts.
It's trying to get out. Okay, so try and once you see a good opening in the mouth, try and now bring the baby closer to your nipple, and make sure that his chin, the bottom of his chin is touching the bottom of your breast.
Okay.
Right. So
okay.
Ow. I think I'm not doing good at the position.
I think you're doing great. Okay. So I'm really, thank you so much for doing that. Yuli, you get extra points and stars. So it's not easy to go first. It's not easy to do that first thing in the morning. And it's not easy to do it in front of all your peers, right? It's much easier when you're working one-on-one with somebody. Yes. You've created some rapport. You know what you're doing. You're in your zone. You can see better. Yeah. And this morning, you just came to listen. So you're like, okay, great. Now I've got to do my thing. So you did a great job. And you touched on a lot of the things that we really want to touch on when it comes to our basic latch and positioning. And so the very, very first part of this, we're going to spend the next, this is a guess, but 10 to 15 minutes talking about just the basic tenets of latch and positioning. This is stuff that you already know, but it's also really nice to see it in terms of what are the things that we have to make sure that we're touching on. And Yuli touched on quite a few of those. So let's get into that primarily. All right. So when it comes to latch and positioning, when we always want to start with positioning, right? Good latch is we are unable to achieve a good latch until we've established a good position. So whenever we're addressing positioning or with a dyad, I want you to remember, it's really helpful to remember there's always going to be positioning for two things, right? There's always going to be positioning for the lactating person, and there's always going to be positioning for the infant. So when it comes to the lactating person, the first thing you want to do is you want to assess their comfort. Okay, so you want to look at their support. You want to look at their support for their back, support for their arms, support for their feet, and support for their legs. When we're talking about comfort for the lactating person, we have to remember that this is something we're hoping that they're going to continue to do for a long time. If I had you do something twisted like this or lean down like this 12 times a day for an hour, you would get sore, and the next day you wouldn't want to do it anymore, right? So we want to make sure that you're addressing all of those things when you're addressing comfort. Just give a good scan. So if I'm working with Yuli, I might say something like, how are your legs feeling? Are your feet flat on the ground? Do you need to get a stool to lift your legs up? How's your lower back? I know you just gave birth. I know you're sore. Do you have a lot of pressure on your perineum right now? Or are you feeling you're in a comfortable area? Do you have anything to support your arms in the chair or the sofa or whatever it is, the bed that you're laying on right now? Do you feel, 7 pounds, a 7-pound, 7-ounce baby can get very heavy on one arm after a certain amount of time. So you want to check and for comfort first primarily. The second thing you want to do, of course, is just, again, give a good scan, ear, shoulder, hips, all in alignment for this person. Otherwise, we're going to get sore. The next thing we want to look at is the infant's positioning. The very first thing that's most important about infant positioning is you want to establish security. And Yuli did this right away, right? Do you remember I was holding my baby like this, up facing upwards like this, and she said, go ahead and turn that baby towards your belly, right? So I had my baby nice and close in, and my baby was belly to belly. And we have to remember that infants are prone eaters. So actually their biological feeding position is tummy down. And so whenever we're using any position, whether we're using our cradle position, whether we're using our cross cradle position, if we're using our football position, or we're using our laid back position, we have to remember that pressure on the belly activates all of those inborn feeding reflexes, okay? And so belly to belly is an absolute essential infant positioning tip. From there, you want to assess alignment of the baby as well. So the lactating person's all aligned, baby's all aligned, ear, shoulder, hip. And this is true in any position, right? So we have ear, shoulder, hip in the cradle, the cross cradle. We have ear, shoulder, hip in the laid back position. We have ear, shoulder, hip here in the football position or the clutch position, right? And even if we turned clutch this way, which sometimes works for babies depending on breast shape, you still want to look ear, shoulder, hip. Right? So I know that many of you have done this in class before, but let's go ahead and do it again because it's a great reminder and it's a great teaching tool for your clients. I want you to take your head and turn it all the way to one side, please. Try to swallow. Difficult, yes? Miriam's like, it's difficult to swallow with your head to the side, and it's difficult for babies too. So the way that this looks at the breast, when we're out of alignment, when the infant is out of alignment, what ends up happening is the infant will go onto the breast and latch on like a pro. They'll swallow once and they'll come off, right? And then we have a mom who's saying, I'm not sure why they don't like me. They don't like me. They keep coming off, right? They won't stay latched. And all of that has to do with primary positioning. The next thing that I see that's incredibly important to remember is that positioning protects the airway of the infant. And this is huge, not only for, it's really for all infants, but I really want you to think particularly about your late pretermers and your preterm infants, okay? So we're talking about babies in general having very weak neck muscles and not really being able to lift that huge head and position it in a place that's most comfortable for them, particularly when they have a nice strong adult who's positioning them for themselves. And so you want to remember that the best feeding position for an infant to protect their airway is with their chin slightly raised, very similar to how you might take a drink of water, okay? And the way to ensure that baby's head is slightly raised is to always attempt to line the nose up with the nipple. So when I talk about positioning with a parent, I obviously don't go through all of these things, because by the time I've gone through all of these things, that baby's either latched on and she's in a lot of pain, or they've completely tuned out. But instead, what we talk about is just the basics. So we want to hold our baby close in. We want to make sure our baby to belly is belly to belly, baby's in alignment, ear, shoulder, hip. And we want to make sure we've lined up nose to nipple. Now, I want you to see something when we talk about positioning in the cross cradle position, because so many people use this position. I'll make myself bigger here for a minute, okay? Use this position, right? When they're establishing a latch, when they're struggling with latch and positioning. And so when you'll notice here, can you see my baby's mouth lined up with the nipple? Just lined straight up with the nipple. If I were to bring baby in at this angle, I am actually bringing baby in with their head tucked down this way, right? So baby comes in straight to the nipple and tucks their head, chin going down. Exactly what Yuli said not to do, right? Yuli said, bring the chin in first. The question is, if we're aligned up nose to mouth, it's impossible to bring the chin in first, because if you bring the chin in first, you miss the nipple. So you want to make sure that the nose and the nipple are fully aligned, and you really want to exaggerate it. So when you have parents in this position, and this is what you're seeing very often in a virtual consult, you want to say, please exaggerate baby all the way over this way, right? So you're actually probably going to see, depending on the size of the areola, you're going to probably see some areola here towards the top of the head, right? And what we really want to encourage is that baby then has to reach up, right? Reach up and back to come on to the breast this way. That will bring baby up in this position, okay? So that's our basic positioning. Everybody with me still? I know we're going through it fast, but this is stuff you already know. So I'm not trying to bore you with the stuff you already know, but it's very important that these little things, these teeny little things, are going to affect the ability for baby to latch. And so establishing that good positioning from the get-go, right from the start, is going to be something that's going to be essential. Okay. So then, of course, once positioning is firmly established, then you can move on to latch, right? And establishing a great latch can really come very naturally, especially when it's baby led. But when it's not going so well, you really want to address a few key things to help make sure that things are more comfortable, okay? So the first and foremost, we want to teach how to compress or shape the breast. I cannot emphasize this enough, right? There's really there's this important general understanding that a lactating person's breast and nipple areolar complex is really made perfectly for their individual baby. But sometimes initially we have a little bit of a mismatch, right? So we've got like large breast, small baby mouth. And that can cause a lot of pain in the beginning. And so just to drive home how essential mastering this skill is, I'm going to show you a little activity. And I wish if we were in person, I would have you all doing this as well. But instead, you're just going to have to watch me do it. And maybe it's something that you would want to show your clients in a prenatal appointment when you're talking about some of this stuff. But it's going to require, first and foremost, for me to put on, I don't actually have any lipstick. I'm not a lipstick wearer, but I have a little lip gloss. So I'm going to put some lip gloss on real quick, okay? All right, a mirror for you and lip gloss. You're welcome. All right, and I traditionally use a balloon for this, but I didn't have one, so I blew up a glove. We all got gloves laying around, so you'll probably have these things too. You can do this with chapstick. You're probably going to want a marker as well. But I want you to see here, let's use this side. So we're going to use this side as this is going to be the nipple area, and this is my breast, okay? And so very traditionally what happens is we have big breast. I don't really have that small of a mouth, but we'll pretend I have a little bit of a smaller mouth, or maybe I've got a large baby and a medium-sized breast. And typically what happens is, again, lining the nipple up to the mouth, breast comes at baby, baby opens wide, goes straight on, okay? So what I'm gonna do here is I'm gonna mark off, hopefully in a way that you can see, over Zoom? Let's find out. Can you see those marks? Okay, that's where my lips hit on my breast. Now, and I know that you all teach this, I am going to take my breast. I'm going to compress it. I'm going to tilt it up towards my nose, and I'm going to roll it in. Are you ready? That doesn't taste good. And I'm going to show you where. Can you see? This is my top mark. And look, if I roll the breast all the way down, look at how much more breast I was able to get into my mouth, right? I cannot emphasize enough the importance of breast compression or shaping when we are trying to address nipple pain and latch, okay? So that's going to be the next thing that we want to make sure that we are teaching when we are teaching parents. Let me move you all over here so that I can see my own slide. So we want to make sure when we talk about breast compression, just like we did with the balloon activity, yes, we are talking about actually compressing the breasts, but we always have to check our direction. And what I mean by that is I can't tell you how many times I have seen parents come in, I'm in so much pain. And this is what I was taught. Compress the breast. I'm doing cross cradle. Compress the breast like this and put the baby on. When you compress the breast in a C position, in a cross cradle, what you've done is you've now taken your balloon, your breast, you've compressed it this way, and then tried to put it in the mouth. It's not going to make any sense, right? It's like trying to take a cheeseburger, turning it on its side, and trying to get a good bite. You have to make sure you're compressing in the same direction as baby's mouth. This seems like completely like an of course, right? Like, of course, that's what we would do. But I can't tell you how many times I have seen that this is the one correction that we make and latch and positioning is fixed. So really check your directions, right? You want to teach that in any position. So let's go ahead and go in the cross cradle position. When we're in the cross cradle position, we are not compressing in a C. We're compressing in a U with your hand all the way underneath the breast. What I often say is think of the underwire of your bra, right? This brings hands back from the areola, which is very, very important so that fingers don't get in the way. And we're actually compressing in the right direction. From here, you can take that nipple and you can point it away from baby, right? So we're pointing it away from baby this way towards baby's nose, just like I did with the balloon. And I'm rolling it into baby's mouth as baby comes on, okay? The actual latching, of course, has to begin with eliciting that wide open gape. And so after you've established that effective shaping in order to best utilize the infant's inborn feeding reflexes, you want to teach that lactating person to use their nipple to make contact with baby's nose, run it down the philtrum all the way to the chin. And this step should be repeated several times as baby practices opening until that parent sees the baby opening really, really wide. And so you remember you will be telling me that, right? Are you seeing the baby open wide? And so likely this is going to take some practice for a new parent to identify. And your job is to watch really closely and to point out each time the baby opens until the parent starts to notice it on their own. Okay. The next step here is we want to use the shoulders and the base of the neck to bring baby in. Just as Yuli said, we want to go chin first, and this is only possible when we have good positioning, right? Nose to nipple, chin in first. What happens with infants when my hand is in the right position, if I bring their shoulders in, it flexes their head back, right? So bring shoulders in, it flexes the head back naturally. And then of course, we have to do this quickly. And this is one of the hardest things to teach parents, particularly if someone's in pain. So if you were in pain anywhere in your body and I said, bring in something as quickly as possible to latch onto that spot, you'd be like, Absolutely not, right? And so we have a natural hesitation. And sometimes the hesitation in and of itself can create a latch that's continues the pain or perpetuates the pain. And so you do want to teach that they bring the baby in swiftly, but sometimes you have to teach a little bit of a cheat. And so a couple of the cheats that we've talked about thus far is actually using the weight of that breast to fold more tissue into baby's mouth, right? And so again, remember, if I'm baby and I'm nose to nipple and you're compressing breast, tilting up, you can use the bottom of the breast to hit the bottom lip first, roll it, pushing down on the chin to open the mouth a little bit wider, okay? A little bit more of an advanced cheat for you is to use the closest finger, the finger closest to baby's chin, to actually hold the mouth open for just a millisecond longer. Again, because you're not hands-on, you're likely virtual for a lot of your clients. This is a hard one to teach, but every once in a while you'll have a dyad where the mom is just so used to handling that baby that you can go ahead and say, you know, with baby in a cross cradle position here, this finger right here that's closest to baby's chin, I can actually use this finger as baby comes on to just press on baby's chin, just ever so slightly. Just keep it open that millisecond longer until I can get baby latched on. Okay, so those are some of your cheats. Once baby is latched on, we want to look for a couple of things. Okay, so we have 4 signs of good attachment. I know this is review for you. Hang in there with me. Okay, everyone. We have 4 signs of good attachment. Number 1, we want to see more of the areola visible above baby's top lip than the lower lip, right? What is that called? Anybody know what that's called? Anybody remember? No? Okay, it's all right. It's called an asymmetrical latch, right? So when the baby's on there, you see more of the areola on the near the nose than you do towards the chin. It's called an asymmetrical latch. The second thing is we want baby's mouth wide open, right? Like Yuli said, we want to look at the angle of baby's mouth. It should be at a 140-degree angle or more. The baby's lower lip is going to be curled out and the baby's chin is going to be touching or almost touching the breast. So we're going to take a look just really quickly at a couple of those examples. So here's what I was talking about with more of the areola visible towards baby's top lip than lower lip, right? So when you're taking a look and assessing once parent has gotten baby latched, you want to take this nice overview look and you want to look in there and go like, okay, I'm seeing this great asymmetrical latch, right? So we're not perfectly right in the middle. We're slightly off with a little more of the bottom of the breast towards baby's chin inside the mouth, right? Nipple pointing up toward the palate. Second is the mouth is wide open. I don't know if you can see the angle of this baby's mouth here, but you can see it's way larger than 90 degrees, right? So 90 degrees is here. We want to see it open even more than that, 140. This baby's almost like 180 degrees. This baby's like 160 degrees open. It's a nice wide open mouth. You want to check for that. The next thing you want to look for is you can see baby's got this little tucked little lip right here. And probably this is a somewhat comfortable, but sometimes we get a little pinching when we have a tucked lip. And so what you can do is just take the finger, teach parents to take the finger, put a little bit of pressure on the bottom lip, and that will just whoop, roll the lip right out. And so you see this great angle and this bottom lip curled outwards like a little bit of a fish. And then of course you see here baby's chin touching or almost touching the breast, right? When we have a lot of nose touching the breast, chin tucked down, baby's gonna absolutely either compensate with their mouth or pull all the way off the breast, because remember, right, in this position, go ahead and put your chin down and try to swallow. Just put your chin down and imagine just having to stay there and breathe like that for 45 minutes. It's not comfortable. And remember that that's all the things that we're addressing when we are addressing infant positioning. Okay, so everyone got that? Everyone good? Everyone with me so far? I'm going to scan through your faces and see. Can I get a thumbs up if you're with me so far on our latch and positioning 101? Stuff you do every day, you absolutely know, and yet refreshers on it are always good, right? Even my clinical students, we refresh on latch and positioning all the time. Thank you for the thumbs up. So that was easy. That was easy and the webinar's done. I'm just kidding. It's not at all easy, because here's the thing. Is it easy for us? We've gone through it now it's been about 20 minutes that we've gone through all this, and we're going, great. Well, now I can fix everyone's problem. But the thing that we have to look at is, if it's so easy, why do so many parents struggle with it? Why are we still struggling? Why is the number one complaint when we are breast and chest feeding nipple pain? Nobody knows the answer. I don't know the answer either, but I'm going to take a guess. Well, Yvette knows the answer. Tell me.
One complaint you said?
Yeah, I said the number one complaint, right? It's nipple pain, isn't it?
Yeah, nipple pain, or I also get like my baby's very fussy, doesn't want to latch on.
Yeah, it doesn't want to latch on. I get this all the time. And we'll talk a little bit about our infant reflexes and my baby doesn't want to latch on, because that's a one I see all the time as well. My baby doesn't want to latch on, and nipple pain. When my baby does latch on, it's very uncomfortable. So what I want to know from you is, who here knows how to drive a car? You can just give me okay. So I'm seeing vast majority of you know how to drive a car. Okay. So I'm really glad to hear that, because now that I know you know how to drive a car, this afternoon for the rest of this webinar, we're actually going to go over to the racetrack. We're going to get behind the wheel of a manual transmission, right? That's like a stick shift car. And then we're going to race it. Everyone in? Not really. Ashley's like, nah. Oh, and also I wanted to let you know that the stakes for winning the race are really high, because only the winners get to keep your jobs. You're like, what is she talking about? Well, this is a little bit what it's like for new parents, some of whom have held a baby before. Maybe they've seen a baby eat. Maybe they've been a part of feeding baby, but usually with the bottle. And this is a little bit of how they're feeling when it's time to feed their baby with their body for the first time. So while they might be somewhat familiar with the general act of holding and feeding babies, it's likely going to take a lot of specific directions. It's going to take many, many, many deep breaths, and it's going to take a lot of practice before they're pros, right? So there's ways that we can help with this. And it seems simple, but I can't tell you how many times we jump straight from, oh, you know how to drive the car? Let's go to the racetrack. And so often what happens is parents are left somewhere in the middle, not knowing at all what it is they're really supposed to be doing. So with that said, the ways that you can help is we are actually going to focus on pre-positioning and latch. Okay, and this is a really important thing to go through with parents, unless they are a very, very overly experienced parent. And even if they are, I think it helps them get in touch with it. So the first thing that we talk about is we want to do a baby head to toe. So how do we get to know your baby head to toe? We start literally with the head. So often what I'll do is we'll lay baby down and I'll say, let's talk about, or if I'm doing it virtual, then I'll have my baby doll and I'll say, let's talk about your baby from head to toe. So if we start at baby's head, then we want to recognize that baby has these soft spots, the front and the back, called fontanelles, right? It's normal to see those pulsate a little bit. These are also a great indicator for us that baby is hydrated. They'll be naturally a little bit compressed, but we're never going to see them sink really, really far down into the skull. And if we do, then it's a good indicator that baby's not getting enough, right? Getting enough to eat. And so we want to keep an eye on those. And this is important to teach about because many, many, many of our parents, especially during the winter, they like to keep hats on babies, right? Babies' heads are a little pointy, or they're really concerned that everybody's cold. And where it's true, babies can't regulate their own temperature. To keep a hat on a baby all the time, 24 hours a day, it robs us of the opportunity to really watch the signs of our baby, the health signs that we can get in contact with. So you want to teach a little bit about that. You want to talk about the early senses of baby. So in the beginning, as we go down from baby's head to toe, you'll notice your baby actually has really terrible eyesight. Their eyes might cross in the beginning, right? One's looking one way, one's looking the other. This is normal. Their eyesight is very underdeveloped. As a matter of fact, babies can only see about this far from their nose. But when we take it and we turn it down, guess what? Babies can see only this far from their nose. And this is on purpose. This is so that babies can really focus in on their primary caregiver, the person that they're supposed to be bonded to for survival. Babies have a very, very sensitive sense of smell when they're born. This is all to locate the breast and to locate where they're supposed to be feeding. And again, for bonding, so they know they're human, right? You're my human, I smell you. And touch is one of the very first senses to develop when we are embryos. And this really speaks to how important touch is for babies. Touch is one of the most important developmental factors when it comes to engaging infant senses. In that said, their little hands, right? They use their hands as this little GPS when they're going to find the breast. And so having baby wrapped in a burrito, having baby's hands covered, and we know they scratch themselves. So I understand when we want to have those hands covered. But sometimes if we're struggling with feeding, those things can keep us from utilizing our biological reflexes. So speaking of reflexes, your baby was born with these amazing reflexes that help to support infant feeding. And so a few of them you may have recognized right from the beginning. When baby was born, baby came to chest here, hopefully, and sometimes not, but eventually baby comes to chest. And maybe you noticed baby was moving their legs like this, stepping, right, against your soft postpartum belly. That stepping reflex that they exhibit, that's all so that they can actually crawl from your belly to their source of food. The second reflex that you'll notice that they have is if you put them on their back, babies will actually act like they're falling off the Empire State Building, right? They have what's called the Moro reflex. You'll notice if you put them on their back or you were to sit them up and drop them like this, they're gonna go like they're startled. And so in order to quiet that reflex, we put babies on their belly. Babies are belly eaters. They're prone down belly eaters. So when you put baby prone on mama's chest this way, that reflex quiets. Okay. The other reflex that they have is called the rooting reflex. And so if you brush their cheek, this is a fun one for parents, brush their cheek. If they're hungry, they're going to turn towards it, right? And so the way this looks is when they're laying on your chest and they're hungry, they're going to be rooting side to side like this, right? And they also have a bobbing reflex. So they have just enough strength in their neck for them to be bobbing up and down, right? And so between the stepping and between the rooting and between the bobbing, infants would actually be able to find the breast, initiate a latch, and feed on their own with or without the assistance of the parent. The reason that it's important to talk about these reflexes is not that parents are going to then lay the babies on their chest and the babies are going to self-attach and everyone's going to be like laying in a field of flowers. It's because when you take all of these behaviors that are normal for babies and support infant feeding, and you lift them up and put them in this position, what do you typically see? I'll tell you what I see. I see parents trying to then breastfeed. I see babies exhibiting their normal newborn behaviors. This and this, right? Do you remember what it looked like when we were on our belly? It looked like this and this. And now when I'm up, it looks like this and this. And what is it? What do you hear when a baby is going like this and pulling back from the breast? What do you hear from parents?
Exactly what Yvette said. My baby doesn't want to latch.
My baby doesn't
Yeah.
want.
Or my baby doesn't want my breast.
My baby doesn't want my breast. My baby doesn't like me. I get that one too. My baby doesn't like it. That is a really intense feeling for a new parent. And the thing is that you can completely switch that thought by teaching about how all of these behaviors of their baby are actually searching behaviors to support feeding. And that the only reason that they look that way, babies don't know how to say no. They haven't learned it yet, right? And the only reason it looks that way is we maybe have baby in a position that's not supporting their normal newborn reflexes. And so we want to make sure that all of our positioning is utilizing that pressure on the belly and that security in order to use these inborn reflexes to our benefit so that they support feeding and they don't get in the way of it. Okay? All right. So now we're going to talk about breath. Remember, I said it's going to take a lot of specific directions. So we've just given our directions. And now we're going to talk a little bit about breathing. And I know that using breath sounds very alternative, but you have to remember the efficacy of breath work can actually be tied very plainly back to what we know about infant brain development and physiology, right? So infants are born with only 25% of their adult brain capacity at birth. That's so they can fit out a small area, right? And the brain that they're born with is a feeling brain, not a thinking brain. And so what this means is that babies are like this little hypersensitive receptors. They are this highly intuitive, and they lack this ability to regulate their bodies on their own. So while their prefrontal cortex is still developing, infants will rely solely on their care providers to regulate their systems, right? And so when infants are skin to skin, right? We see this in the early newborn stage. It's true to our physiology and not just our neurobiology, right? So when infants are skin to skin, we know with a safe, intimate adult care provider, their temperature regulates, right? Their breathing regulates, their blood pressure regulates, even their sugars regulate. So we, our parents, are the original and most effective incubators for baby. So taking that deep breath, achieving some of that personal regulation, and lowering the stakes is really important to creating an environment at large that can actually facilitate feeding for an infant, right? So when I'm dysregulated, my infant's going to be dysregulated. A dysregulated infant cannot achieve a good latch. So I cannot emphasize enough stopping, calming everyone down, stepping away if necessary, and coming back to it with a regulated adult. Okay. The next thing that we talked about when it came to our race car is, remember, we got to talk about practice. And practice really has to do with handling the baby. So we want to have them place baby on the bed or maybe another flat surface, right? It's got to have enough area around it that there's no chance baby's going to fall. So this is not a sofa. Okay. So somewhere, even if this is the floor, it's a safe, flat space. We want to have them place one hand under the base of baby's neck here, with the heel of the hand between the shoulder blades, and either the first or the middle finger near one ear, thumb near the other ear. Okay. We want to have them practice lifting up baby's head, moving it side to side, tilting it up, tilting it down. These are all the things that we ask them to do at the breast, but we're asking them to do it while holding their breast, while shaping that, while their baby's trying to latch, and while they're in pain. The stakes are way too high. We need to practice these behaviors when the infant is not expecting to eat, right? This is what lowers the stakes, right? So that's like taking the race car to the track when no one else is on it, right? We're letting them practice. Then you want to have them slide another hand under baby's bum. Have them practice lifting the baby, supporting the head and the neck with one hand, the bottom with another. All right? Everybody with me so far on our pre-positioning latch? What do we do when they still can't latch? I've done all that stuff, Hannah, and I've done all that stuff for 10 years, so I already know. What do we do? Okay, well, at this point, we've gone over all the basics. But I actually talked to somebody in your crowd, a little birdie, that told me that you are not actually a basics kind of people. You really want more. And so, the truth is that for the majority of you, basics are what's in your scope. So if you are not an IBCLC, as a lactation educator, your job is to know what we just went over, to know how to communicate it so well that if I woke you up at 3 a.m., I asked you to teach me about positioning and latch, you could do so while you were half asleep, right? That's your job. But we also know that in reality, even though you're a pro and a lot of parents are doing exactly what you have told them to do, many parents are still experiencing prolonged nipple pain from insufficient latch and positioning. And really, this is almost always due to one or both of two things. Okay, so the first is they need more practice. In that case, you either need to repeat yourself or you need to find a new way of explaining it. So as a lactation educator, you really should have between 2 and 3 different ways to say the same thing. And you got to have it ready and waiting just in case the first thing you said got missed, right? The very best way to practice this, I can't tell you enough, is to find the nearest 12-year-old boy in your life. Practice with him just following exactly what you say until he gets what you're trying to describe. Mine is behind me in school on a couch. But we do this all the time, right? So if I'm trying to teach something new, I'll try to teach it to him because he has no basis in this information at all. And so I know exactly the effect of my words. But of course, the second possibility is that it's nothing that you or the parent is doing that's impacting latch. Instead, it's actually the internal structures and the function of the infant that are making that good latch really difficult to achieve. So what do you do in those cases? Well, typically, most responsibly, I actually need to tell you that the very best thing you can do for that dyad is to make a living referral to a lactation consultant who can give a higher level of care. And so when I say a living referral, and no, that's not an official term, that's just a Hannah term, living referral. That's the term that I use to describe the kind of referral that starts and ends with a real living, breathing human being. So it's not a piece of paper, it's not a handout. I want you to think about it more like a handoff, right? But you've really, when you've done everything that we've talked about to establish great latch and positioning, everything on our lists, and you've observed the latch from the outside, and you've seen all 4 signs of good attachment, and the lactating person is still in pain, you must refer, period. Refer them out. That's good care. That's you doing absolutely what you should be doing. That said, I told you I had this conversation with your unnamed champion who told me that you were all the cream of the crop and you really didn't want to stop at basics. So we are going to move into, after a little break, we're going to move into a little bit about how the infant oral structures and function make feeding possible so that you can be like the most educated of the educated educators out there in all the home visiting network. And hopefully, so you can take this information, you can use it to help you inform your observations of breast and chest feeding, and you can know better when a referral is really necessary, okay? Which, like I said, is most of the time. So please never be afraid to refer out. Yes, yes? All right. I see some of you are still here. Many of you are camera off. I get it. It's Thursday. We're going to take a break. And then when we come back, we are going to dive into some of this stuff. It is infant oral anatomy and function. So if you're like, ooh, that sounds freaky, just listen. I'm going to try to make it a little bit relatable. If you want to take notes, you're more than welcome to. It's really just for you if you wanted to do a little bit of a deeper dive to kind of understand what's really going on, what supports lactation from the inside. Okay, so let's take a 10-minute break. I got yelled at for us giving you too short of a break last time by my co-presenter. So let's take a full 10 minutes. Go take care of yourselves. At 10:03, we will be back. All right. Yes, kind of. I'm seeing deep breaths. That's okay. But now that we have all the basics down, we really want to dive deeper into like what makes all of this possible. Okay. So in order to breastfeed effectively, infants must be able to coordinate 3 basic processes, right? We all know what those are. Yes, suck, swallow, breathe. We've heard that over and over again. Suck, swallow, breathe. In order for us as educators or clinicians to better assess this coordination, we really need to understand the basic structures that contribute to these processes, okay? The thing is, it's not just anatomy that contributes to the effective use of the mouth for feeding. Developmental maturity, the right environment, an appropriate state, and of course, sensory integration and processing, all of these are going to play a vital role. And we talked about achieving some of these, right? When we talked about our practice steps to making the correct environment for an infant to achieve a good latch. In order to assess these factors, you really have to look at the whole baby, all right? So you're gonna wanna take into consideration the infant's gestational age, what the muscle tone is looking like, the presence or the absence of those newborn reflexes that we reviewed, the newborn state, the newborn's environment, and of course the birth history, which I know you all take. I want you to remember that infants are competent when they're in their expected environment. And their expected environment is skin to skin, unbundled, belly down, on parent's naked chest, unwashed, unmedicated, right? And so it's in this environment that it helps to activate all of baby's natural instincts to feed. And it's important that we as educators, we can attempt to replicate this environment when we're having feeding difficulties as best we can given modern practices. So that's why we tell people to go ahead and take off baby's clothes. You can remove your shirt, put baby skin to skin. Let's put baby belly down. Let's quiet the room, right? It's really actually important that we look at environment to help and assist baby using their natural feeding instincts to facilitate feeding. So in one of our human lactation textbooks, they refer to the infant's mouth as the cockpit of awareness and the principal site of interaction with their environment. So the oral anatomy, the facial and pharyngeal regions of the developing infant, they develop extremely early from the neural crest cells at like about the time of the neural tube closure, right? So that happens really early. We're talking 4 to 5 weeks gestation. And the fetus can then be seen swallowing amniotic fluid as early as 11 weeks. Right? And then they develop that suck reflex at around 24 weeks gestation. So the link between sucking and swallowing, that's not seen until sometime later. So they have that ability to swallow, but that link between the sucking and swallowing, that really requires a good deal of neurological development in order to synchronize. So that's not happening until quite a bit later, okay? The oral cavity of an infant, it consists of the lips, right? We're all familiar with those. If it's going to be hard for you to remember, just locate it on yourself, right? So it's our lips, our lower jaw, our upper jaw, sorry, we'll start with the upper jaw, the maxilla, our lower jaw, the mandible. We've got our cheeks, right? Cute baby cheeks. The tongue, we've got the floor of the mouth, we've got our gum ridges, and we've got, of course, the hard and the soft palates, and then behind that, the uvula. All right, when we compare it to an adult here, you can see that the tongue of the infant, it fills the oral cavity to create appropriate intraoral pressure and to help shape the palate. So when we compare it to an adult palate, you feel your palate right now with your tongue. It's deeply arched upward, right? The infant's palate is actually short and wide at birth. Anteriorly, which is in the front, we have that hard palate. That works with the tongue to compress the nipple, to maintain its position. And posteriorly in the back, we have our soft palate. And that seals to the back of the tongue during our sucking, and it elevates to seal off the nasal cavity when we swallow, right? So the hard palate is actually shaped by our tongue movements. And that's why we need to pay close attention to the shape of the palate, right? So if we have a baby that has a really high or overly arched palate, that could be an indicator of a possible tongue tie, right? Where does the tongue actually rest in the mouth, right? One of the researchers who talks about palate development, he actually likened the palate to soft wax in the early days of oral development. And this was like in an attempt to describe how incredibly malleable that palate is to alterations depending on what you put into it. So we're talking about pacifiers, breasts, bottle, right? This is going to have a huge implication on our oral facial development, possibly on our airway, on our breathing, and of course, the host of other things that go along with that, including sensory issues, learning disabilities, and overall growth changes. So how our oral structure develops, what we suck on as infants, actually affects us forever. Many of us have our palates looked at when we're in our orthodonture stages. When we get to the tongue, we want to remember that our taste buds are present at birth, and there are definitely some studies to show that infants will suck faster in response to sweet taste. So breast milk is very sweet. The anterior tongue, right, or the front of the tongue, this moves as a stiff body. It goes along with the jaw, right? So it holds pretty still during feeding. The posterior tongue, that's what undulates in that peristaltic wave, which creates a subatmospheric pressure that draws milk from the breast. It moves a bolus of milk, so a collection of milk that happens in the central groove of the tongue back into the pharynx, okay? So when you think of the tongue, we have the front, I'm gonna put my tongue like this, okay? The front of the tongue here stays relatively still during feedings. The back of my tongue is going to move. I can only move the front of my hand. How can I move the back of my hand? I'm not that coordinated. Let's see. Okay. I'll move the back of my hand like that, right? It'll lift up and it'll fall back, and it'll lift up and it'll fall back. And so when we are talking about latching positioning, if we have a tongue where the front of it is not able to extend and pull underneath here, right? And hold that breast in place, what we have is we have a tongue that's constantly going like this in the front. That's going to be very painful. And it's also not going to facilitate what I talked about, that pressure drop, that sub-zero pressure to pull the milk out, right? So not only do we have pain, we also have insufficient transfer, okay? When it comes to the lips and the gums, once the tongue kind of draws the nipple and the areola into the mouth, the lips then seal around the areola, and they need to create an airtight closure around the breast. All right. And then we have the epiglottis. Different than an adult, the epiglottis in an infant lies just below the soft palate, and it really protects the infant's airway by directing milk around the trachea and into the esophagus during swallowing. Okay. I want you to think about this whole situation a little bit like a box. So on either side, we have these buccal fat pads. Those are our cheeks, right? We have our little baby cute cheeks. We're going to talk about those later, but those are really important. When we have really, really preemie babies or babies with not a lot of fat reserve, we tend to have latching issues because the buccal fat pads create the seal on the outside of each box, right? We have the palate on the top. I want you to think about what an intact palate looks like. Well, we already talked about it being shallow, it being wide. And when we have any alterations in that, we have cleft palate, right? We have palate that's highly arched or a bubble palate. What's that going to do to creating the seal that's necessary to create the pressure to bring the milk out? And then, of course, we have the tongue. When we have the tongue operating properly, we talked about how that facilitates milk transfer. But when we have the tongue has a restriction, right, and we can't use the tongue the way it needs to be used, then we also have an issue. Any issue with any of these, the top, the sides, the bottom, are going to create a latching issue and a transfer issue. I want you to think about latching and transfer as almost the same thing. Anytime there's a latching issue, we are going to have a transfer issue because of the function of the oral structures. Yes, yes? Okay, I'm seeing nodding. I believe you're with me still. Okay. So sucking and swallowing, those develop in the third trimester. The physiologic maturation appears to have a greater influence on the development of nutritive sucking, right? So our physiologic maturation, how old we are, has this greater influence on our nutritive sucking abilities than experience. So there's definitely some evidence to support that experience plays a role in the development of nutritive sucking, but we have to remember that this is largely driven by neuro development. So the swallowing reflex, we talked about, not completely functional until 34 weeks. right? So our nutritive sucking can be demonstrated by infants at 26 weeks, but that rhythmic pattern, it's not developed until 32, 34, and that true synchrony of the suck, swallow, breathe, right? That 1 to 1 to 1 pattern, suck, swallow, breathe, suck, swallow, breathe. That's not going to occur until 32 to 34, maybe even later for some infants, 36, 38 weeks. So I want you to think about this practically. What does that mean for your 35 weeker, right? When we're talking about latch and positioning, what does that mean? Sometimes for your 37 weeker, people will go like, well, the baby was full term. Maybe not for that baby. We are not sure. So we really have to, was it a spontaneous labor? We have to be looking at baby's actual development, give that baby a little bit more time. And of course, that epiglottis we talked about lying over the soft palate, infants have like really specialized anatomic structures and configurations to support that sucking and swallowing and protect their airway all at the same time. Okay. Baby, we talked about using the hands and the cheeks to locate the nipple, right? Why it's important for us to be unbundled, belly down. That's how they find the nipple. They extend their neck. They lead with the chin when they do it individually. When the nipple touches that philtrum, we talked about it as the open sesame, the baby will open wide. When the lower lip encounters the breast, the baby will extend the tongue. Ever touch a baby's lip down here? They go, meh. Right? And it's a reflex of ours. So it will touch, baby will extend the tongue, the baby will lunge forward, grab the nipple, create that seal using the gum, the lips, the tongue. And remember that tongue is cradling the underside of the breast and then cupping upwards like this, right? Then that's when the back of the tongue drops away to rhythmically create that vacuum. It used to be thought that infants used their tongues, the front of their tongues, to massage the breast ducts under the areola like we would do with hand expression. But it's actually believed now that it's that negative pressure created by the back of the tongue that creates the vacuum to extract the milk. And of course, it's that in conjunction with our ejection reflex on the parental side, right? So without the milk ejection reflex, we're really only getting a fraction of what's optimal from baby. So baby only does part of the work. The parent has to do the other. So we have to make sure we're also, when we talked about comfort for the parent, we think of this as like, oh, she just said put the mom in alignment. No, actually, mom needs to be very comfortable because we need to protect her oxytocin so that she can have this milk ejection reflex so it can facilitate transfer. All of these things are tied. We don't say them for no reason. Sometimes things are said for no reason. We didn't say them for no reason. There actually is either an anatomical or a physiologic reason for all of the basics that we just went through. Okay? You want to make sure you're observing the whole baby. So you want to look at any asymmetries that are happening. Is their mouth open at rest? Is their tongue protruding at rest, right? This would be something that would be somewhat abnormal. During relaxed sleep, the tongue's supposed to lie against the roof of baby's mouth. This is what creates that wide U shape that's best for their jaw and their airway development. Some did you knows here, okay? So did you know? And remember that these can be checked not only by an IBCLC, these can be checked by a parent. I can't tell you how many times you get to say, guess what? You get to touch your baby. That's your whole baby, right? So you get to touch inside baby's mouth if you wash your hands. You get to touch on baby's face. You get to know your baby as well, if not way better than any clinician could. So touching the roof of baby's mouth, that's going to elicit sucking. So when we have a baby that is at the breast and going like this, who was telling me? Was it Yvette? You were telling me the baby's like this, right? We might have a baby with a particularly high arched palate. We might have to use breast compression and the tilting of the nipple to tickle the soft palate or the hard palate, tickle the roof of the mouth, and then all of a sudden baby will go, oh, and start sucking, right? So we really have to talk about using breast shaping. Sometimes rubbing the palm of a baby can elicit sucking. Crossing the baby's arms and legs in front of them will calm them down. We talked about regulation. Pressing on the gums without the tongue there, it's going to elicit a bite. This is why it's so important that we have to make sure the tongue can extend all the way past to the lower lip. Because if we have a tongue that's sitting behind that gum line, what's it going to look like at the breast? Right? She's going to say, I feel like he's chewing on me. We want to inserting a finger into baby's mouth, of course, will elicit that tongue thrust. Honestly, you don't even have to insert a finger. You can just start to rub baby's lips and baby's going to go like this. Sweeping a finger along the side of the tongue, that's going to elicit that transverse tongue reflex, right? So the tongue will follow you here, show you that it can lateralize a little bit. All right, when it comes to the lips, we talked about already how the lips are going to draw the breast into the mouth. They're going to work with the tongue to form that tight seal. This is really, really important. Our lips are important. We talked about fishy lips. It's not just because we said they should look cute and they should be tucked. If our lips are tucked like this, it's going to break the seal. In order to create that good seal, we have to be able to have our upper lip up, our lower lip down. That lip seal facilitates the negative pressure that we talked about inside the mouth. Baby's lips should be responsive to touch. So if for some reason you're not seeing that the lips are responsive to touch, then we have hypotonic lips, right? Which means that the lips have like low muscle tone. And for some reason, low muscle tone lips are not going to be able to create that seal necessary to facilitate transfer. They should be able to maintain a closed lip position while they're awake and while they're asleep. So if you're always seeing that baby's like this, always, we might want to look, we might want to refer out. We want to observe baby's ability to seal on the breast, the finger, or a bottle nipple, right? So if we're not able to achieve it on the breast, go ahead and teach parents, let's wash our hands, make sure our nails are clean. We can put our finger into baby's mouth, pad side up, right? So here's my baby, pad side up, and touch the palate. Is baby able to establish a seal? Can you feel baby's tongue curling around your finger and creating a good suck? If you really close your eyes, and you're not going to do this with babies, obviously, because we're not touching babies, but parents can. If they really close their eyes and they think about the tongue, the anterior part of the tongue that's hitting this part of their finger, it's going to hold relatively still. Remember, we talked about that. They're going to feel the back like a wave, rubbing the back of or the front of their finger, okay? Blanching around the lips after feeding, or that suck blister, that can sometimes indicate babies using those lips to compensate for something else. So we want to look at that. All right, the philtrum. That's that groove between the nose and the upper lip, right? This is indicative of good lip tone. Infants that have thin cheeks, sometimes they also have very flat philtrums. We also see this with fetal alcohol syndrome. Yes? No philtrum. Total absence of the philtrum. Oh, I just said that. Touching that top lip or that philtrum, that's gonna elicit that wide open gape. We need to teach parents, what is our open sesame button? It's right here, right? So we go all the way from the nose down to the chin. With our buccal fat pads, we talked about those. You can see them really depicted very well in this chubster. And then we see here, we have slightly less in this teeny tiny baby. These are going to provide that structural support for oral and pharyngeal function, okay? They influence that lip seal, and remember that our preemie babies, our low birth weight babies, they often have that immature development of the subcutaneous fat pads, okay? So we are probably going to see some latch issues with those babies. Our jaw and our chin, they provide the stability for the movement of the tongue, the lips, the cheeks. When you're looking at the jaw, you want to make sure that the motions are smooth and regular. So as we're watching baby eat, and I've got some videos for you if we have time to get to them, but you want to make sure it's smooth and regular. If you're seeing what we call the snapback, which is kind of the jaw, instead of going like this, it's like, right? Almost like it has a hinge in it a little bit, then we've got something going on. So small, wide jaw excursions, we just talked about that. The chin is gonna be somewhat receding. However, if you have a severely receding chin, get them checked for tongue tie, okay? Because we talked about how the tongue sits in the mouth, shapes the palate, also a severe restriction on the bottom, right? On that philtrum underneath, at bottom, not philtrum, excuse me, that frenulum underneath. A severe restriction is also going to cause a severely receded chin. Okay, so retrognathia, that's that severely receded chin, coupled with that high arched palate, that's going to be really difficult to overcome on its own. All right, let's look at this cute baby tongue. It's got to be able to, the function of the tongue is so important. It has to extend past the lower gum line. We talked about that. Otherwise, we get biting, right? That phasic bite we get. It has to be able to lift, and it has to be able to form that central groove. So it's got to be able to cup up like this. It's normally soft rather than rigid. It's usually thin rather than thick. Some of the abnormal presentations, of course, our tongue tie, we've all heard about that, right? We're not able to use the tongue because underneath the frenulum is either thick, it is really, really anterior, so it's inserted at a very forward place, or it's very short and tough. And so it's restricting how the tongue can be used. The tongue itself can be short. This is without any issues of tie. It can be bunched, it can be retracted, it can be flat. There's so many things that can go on with the tongue. That tongue protrusion caused by low tone, or it can be caused by chromosomal abnormalities. So sometimes if you see a tongue that's hanging out like this, right? Abnormally large tongue, of course, that can happen. We can have high muscle tone that can cause some retraction. And we can, of course, arching. You'll see this a lot to keep that airway open. Sometimes there is it is like a congenital softening of the tissues of the larynx. And it's the most common cause of noisy breathing in infancy. Really, really noisy eaters. Usually they grow out of it and it's not harmful, but sometimes, right? This is that laryngeal structure is malformed. It's a little floppy. It causes those tissues to fall over the airway and partially block it. So if you see that there's a lot of arching combined with that really, really loud noise, you want to refer out. Okay, the palate here, we talked about it being U-shaped. The hard palate composed of several bones that touch in the center and the back, right? So you can feel your own hard palate closest to your teeth. Not your hard palate, you can feel the bones actually. They also touch other bones that create our nasal areas and sinuses. Remember, I said this several times, but the palate is shaped by the tongue. Our tongue position will affect our palate and our airway. So there is so much growing research on how our palate shape and how we have used our tongues in our early infancy and through our development have impacted things like not just sensory disorders, but I think I talked about already, learning disabilities, et cetera, and all has to do with our airway, right? So have you ever seen a child who walks almost entirely on their toes, right? Have you ever seen that? I'm getting a nod, maybe 2 yawns. Okay. Well, think about it. If your airway was always kind of compromised, right? If you always were kind of trying to get a little bit more air, what would your posture do? For me, when I think about it, I come forward a little bit, right? Like I walk a little bit more like this. I'm trying to kind of get just a little bit more air, and that might bring me forward and up and onto my toes. So it really affects our entire structure. Remember that long periods of intubation, pacifier, bottle use, all of that can groove the palate to contribute to that high arched palate, which could affect feeding at the breast. The bubble palate, of course, that's like when it's almost like there's a hole. It's not a hole because it's closed, but it's like this bubble at the top. Could indicate that abnormal tongue position or a tongue tie. So you want to be looking at that. All right, let's take a look at cute noses. Babies are obligate nose breathers. So they have to breathe through their nose during breastfeeding, right? They will definitely prioritize breathing over feeding every single time. How does this apply to us practically? Well, when we have baby on, when mom's saying, she's like, I'm not sure if the baby can breathe. You know, there's so much breast tissue and I'm not sure if the baby can breathe. You ask, is the baby sucking? If the baby is sucking and swallowing, the baby can breathe because they will always prioritize breathing over feeding. They will not stay latched. What this also means is, remember I talked to you about bringing baby when you have nipple straight to baby's mouth. what it ends up being is baby ends up with their chin tucked like this at the breast. When they do that, they will suck, and then they will come off and cry. All we need to do is exaggerate baby's position this way, whoop, nose to nipple, reach up to the breast, and then we are head back, airway protected. I see this a lot with my late pretermers. Okay, be very specific about positioning. It's not always latch. We focus a lot on latch, but if we don't get the positioning right, latch is impossible. So we have to make sure you're protecting the airway. Babies can't protect their own airways. We always want to refer for any breathing difficulties, of course, and successful feeding depends on the ability to coordinate that suck, swallow, and breathe. All right, we did it. We got through it. And so what you can see that I have listed here is there are so many factors in determining an infant's ability to suck and their ability to suck well. When basic latch and positioning techniques have been exhausted, it's really essential that you enlist the help of someone that can assess the infant and determine the best path forward, right? And as we talked about before, plain and simple, like latch is important. Latch is so important. It's really so much more about it's so much about so much more than the pain, right? It defines the infant's oral structure. Proper latch dictates milk removal. Milk removal dictates milk supply. And of course, milk supply is critical for continued feeding, right? So we always want to observe a dyad for the latch and positioning, even when pain is not present. And we get this with our older babies, right? You start to talk about how's feeding going? And they're saying like, oh, I feel like my milk supply has dropped a little bit. I'm not sure why. And then you notice that actually because the baby was older, has a bigger mouth, mom's busy doing all kinds of things, latch starts to deteriorate. When latch starts to deteriorate, transfer starts to deteriorate, which means milk removal is happening less, milk supply is going to go down, okay? Why is all of this important to you? Anybody? Why is it important? Well, 41% of newborn readmissions are due to feeding problems. 41% of readmissions to the hospital for newborns are due to feeding problems. And so you are, of course, the frontline workers who can reduce those newborn readmissions. You know, you can reduce them by almost half if we're able to identify these issues from the beginning, either to help solve them or to refer out to somebody in a timely manner. Okay, I have more for you, but I'm not going to give it to you yet. We're only going to do it if there's time. We're going to talk about assessing intake. Before that, I want to really stop and just take questions that you have. I know that was a lot of information and we went over it really fast. So what do you have for me? Has to be at least one question. Nothing. I answered all your questions.
I'm not sure if I missed this, and I apologize in advance. But let's say in the scenario in the very beginning, when the mom was already sore, right? So was Yuli was trying to guide the mom how to do it correctly, but the mom was already sore. So no matter how the baby was going to be positioned, because the pain was present already. Mm-hmm. So in that case, would you recommend maybe give the mom time for healing? And
question, Lorena. This is such a good question. I'm so glad, because practically, right, we can talk about all these things in theory, but practically, what does this really look like for parents who've been feeding? This parent she's 12 hours. She had been doing this with an insufficient latch. So after 12 hours of somebody doing that on your nipple, what do you think nipples are going to look and feel like? Anyone who's experienced this knows exactly, and you're probably like wincing. Anyone who hasn't, you can only imagine what that feels like. At the very least, you're chapped. At the very most, you are cracked and bleeding, okay? When that's true, depending on the damage to the nipple, what we wanna make sure we're doing is, again, there's always gonna be three main priorities. Your main priority when you're assessing a dyad or when you are working with a dyad who aims to breast and chest feed, number one priority is feed the baby. Babies have to eat. That's a non-negotiable, right? The number one priority is we feed the baby. The number two priority is we have to support the supply. Because if we want to have any opportunity for that dyad to continue to offer breast milk, we have to make sure we're supporting supply. The number three priority is actually to fix latch and positioning, right? So we don't immediately go to it if we can't ensure the other two. Now, I would say for this particular case, Lorena, if we go back towards that particular scenario, that we can probably fix the first two by addressing the third thing, right? So then we do actually want to talk about latch and positioning. And so realistically, if you were sore on any part of your body and someone latched onto it like really aggressively, which babies have good, strong sucks, they should, it's going to be initially painful. So when we establish a latch, even if it's a wonderful, perfect, and amazing latch, we're probably going to continue to feel a high level of pain, probably an 8 or a 9, for about 5 to 10 seconds. After 5 to 10 seconds, your pain level should drop down to about a 2 or a 3, depending on your nipple damage. At a 2 or a 3, if it's dropped down, what we know is we're not further damaging the nipple. If it stays high at an 8 or a 9, we know our latch is insufficient and we're continuing to do damage to the nipple, which is not it's really not addressing any of our priorities, right? Feeding the baby, helping support supply, or the latch and positioning. And so we attempt this. Realistically, you want to attempt this. You want to look at what are some things, is there anything we can tweak? But if you've attempted all of it and she's still at a 9 or a 10, we know there's something going on, like we talked about the infant oral structure. There's something happening with the function of that tongue. It has to be referred out. Other than that, I would say that with sore nipples, realistically, and with impatient babies, you want to attempt maybe 3 times with this. After 3 times, we start to lose people. When it comes to nipple care, we want to talk about the number one medicine for healing nipples is breast milk. Breast milk has epidermal growth factor and other stem cells and things that are going to help to heal our skin. So we want to express breast milk. We want to dab that onto the site. We want to wave dry. We never want to blow because it's going to introduce bacteria to an open wound, right? Then we're going to get an infection. And now we've had this poor mom who's having all this latching pain with mastitis. So we're not going to do that. We're going to wave dry. We may want to put on a little bit of, you can use any cream. I don't usually recommend lanolin, but a lot of people come home with this or they get it at the clinic. So lanolin, anything that's like, you can use coconut oil, you can use, they have like nipple butters and other things that you can get at Target and other places people go. A little bit of that, but that's really chapstick. That's not healing what's underneath. That's just creating a barrier between a sore thing and a shirt or a nipple pad or whatever's going to rub up against it, right? All of that should be able to be absorbed before baby feeds again. And that's going to be probably the best way of teaching nipple care. Did that answer your question, Lorena?
Yes, absolutely. Of course, preventing is better than trying to fix it later. But I've just asked a question based on the scenario, but also based on my own experience when I had my baby, and I didn't have any of all this information, and it was very, very painful. It was almost bleeding, and it was really hard.
I'm with you. I had the same experience, and believe it or not, I had that experience with my first. And then I became a lactation consultant and I had that experience with my second jerky little baby, but it just is. I was a parent. I wasn't a consultant at that point. Right. And it's so much different. And I really think we forget all this. You can tell them and tell them and tell them, but like when you are just had a baby and you're sore, you're probably engorged and you're trying to latch that baby on, all of those components together, that little millimeter of space in baby's open, that's going to make a big difference to the placement of the tongue, and that can create a lot of soreness. We know that prevention, like Lorena said, prevention is better than trying to treat it afterwards. However, it only takes one session, one 45-minute newborn nursing session to create really sore, possibly cracked, possibly bleeding nipples. And so what are we teaching people prenatally about latch and positioning? Yes, we're teaching them all of these things, but we're also teaching them, if your baby latches on initially and it is painful, do not tough it out. Nursing is not supposed to be painful. you need to get help immediately. It only takes one session for your nipples to be cracked and sore and bleeding. And then it takes 2 weeks for them to heal. So please, if it's not comfortable initially, you need to see somebody and don't stop asking for help until it's comfortable. Okay? Any other questions?
Hannah,
Yes.
how about nipple shields?
Oh, I'm so glad you said it, Nellie, because it was on my mind. Okay, nipple shields. How many of us is like, oh, put a nipple shield on it? Put a nipple shield, or we just hear from clients. I hear from this all the time. Well, they gave me a nipple shield. Here's the thing about nipple shields is that I want to say as a blanket statement, and others will possibly disagree with me. Nipple shields are not a long-term solution to infant feeding. Okay, so I always want you to think about nipple shields as a bridge to something else. Nipple shield will never fix an underlying problem, ever. So we have to always determine what is the underlying problem to pain. However, if we've determined the underlying problem to pain and that parent is just so sensitive on that breast and it is the only way baby's going to the breast, yes, you can use a nipple shield as just a little bit of a barrier between the baby and the breast. And sometimes that can just give us that little bit of confidence, right? I remember with my second baby, as I said, it was my second time. I knew all the things and I was still bleeding and cracked. I went to go see a colleague of mine, a lactation consultant, and she said, okay, it's time to latch the baby. And I was like, no. It's not time to latch the baby. I don't want to latch the baby. It hurts so badly. And she sat next to me and said, I'm just going to sit here with you. And if he hurts you, I'm going to take him off. And that was all I needed to hear to get the confidence to just go like, okay, I guess we're going to try again. And sometimes things like a nipple shield can be just the thing where it's like, okay, there's just that little barrier and I've got the confidence to try again. However, I'm saying that to you as experienced educators, I can't stress enough that when we just give the nipple shield, we are usually doing a disservice to the dyad because usually the underlying problem, the reason there was pain to begin with, is not fixed. Number one, it still hurts. It still hurts with the nipple shield. Maybe it hurts a little bit less, but they still think it's normal. And so it still hurts. And then they're just using the nipple shield and they've got the pain. What ends up happening there is they get frustrated, milk supply drops, we never really fix the problem, and breastfeeding discontinues. So there should be I've been working with dyads now in breastfeeding for a long time. And I have confidently said, we need to introduce a nipple shield. I think I can count on one hand. So we should not be seeing, I have worked with probably, I don't know what the percentage is, like way over 50% of people who come to me because they were given a nipple shield in the hospital and they want to get off of it. Right? I don't know how many of you have had that experience, right? They're frustrated with a nipple shield. How do we get off of it? I want you to use what you learned about infant oral anatomy to think about how you can get off the nipple shield. Why does the nipple shield work so well? Who can tell me why the nipple shield works so well? Based on what you just learned about sucking reflex, etc. Just guess.
It's like pointed out, right? So it touches the roof of.
That's it. Yep, that's absolutely right. Just like a finger, the nipple shield is long, it's hard. You can force it into baby's mouth. And when that happens, it touches the palate, sucking starts, and babies latch. Now, babies are one of the most adaptive of all mammals. They have to be. They learn so quickly. And because of that, they've learned, okay, something hard touches my palate. That's when I know to suck. That's when I know to eat, right? And when they've done that for a few days, coming off of that can be very difficult because then you put in a nipple and nobody's nipples, I don't care who you are as long as and hard as a nipple shield. You know, I've seen thousands of breasts. I've never seen one like a nipple shield, right? Maybe there's one out there, who knows? There's all kinds of normal, but because of that, your breast shaping techniques are going to be essential. How malleable is the breast? Can we shape it? Can we tilt it up? Can we make contact at all with baby's palate? When we can, we make that contact, babies then are triggered to latch on. Whenever we're trying to come off the nipple shield, we always want to introduce the breast no nipple shield first. You can do this max, I would say, again, 3 is a good safe number. Offer that breast about 3 times, no nipple shield. See what baby can do. After 3 times, parent gets dysregulated, baby gets dysregulated. We've all gone down the tubes, right? Then we put the nipple shield back on. We feed the way we know how, no problem. But the next time we go again, we're going to try without the nipple shield, see what we can do. We're going to increase our amount of skin to skin. Remember all the things we learned about babies, creating the environment that helps to facilitate those newborn reflexes, right? I want you to think back, even with our older babies. You have a 2-month-old that's still on a nipple shield and mom is done. She's like, I am so good. I want to leave my house and I'm certainly not going to breastfeed with this nipple shield out there, right? And so she's like, I think I'm going to just go to bottles. Baby won't latch. Even with that baby, have them create a quiet space together, have them lower the lights, have them get skin to skin, put that baby belly down on mom's chest, recreate the environment that can help to elicit those newborn reflexes that facilitate feeding. You're going to be surprised what babies can do. You want to take that all the way to the extreme, have them get in the bath together safely with help. Have that baby be in the water, nice, warm, body temperature, a little hotter water, and then lift baby up suddenly, right? It's very similar to being born. Put baby right on mama's chest. Cover everybody with some warm cloths and see what baby does. You'd be surprised. All of these, they're so deeply in us, these feeding reflexes. We just have to learn how to navigate them. Unfortunately, what happens with our modern day is that we do everything to quiet those reflexes because those reflexes we consider a problem, right? Babies startle themselves awake. We want them to sleep. We swaddle them. Babies have a high suck need. We don't want them to be bothering us because we just can't be sucked on one more moment. We give them a pacifier, right? We have all these tools to quiet their reflexes. Those reflexes are there to support their feeding and their continued both neurological and physical growth. And so there has to be somewhat of an in-between. I'm certainly not saying that we can never swaddle a baby or we can never use a pacifier or anything. We have to live our lives, good Lord knows. But when we have problems, let's take away all the things that get in the way and start back at the beginning. What else? What other questions do we have? No more questions? All right, then someone else needs to be in the hot seat. Who's feeling like really, really, really ready? Latch and positioning. Everybody's like, not me. Somebody, not Yuli, because she was our sacrificial lamb this morning. Thank you, Yuli. Anybody else? Don't make me call on you. It's okay to be wrong. We get things right much better when we're wrong, by the way. Anybody, Yvette, will you please help me, please? Please.
Sure.
Thank you so much. Like, man, I should have talked up before. Okay. All right. So I have a 12-hour-old infant and I'm showing up to you. I had a relatively, normal, typical, non-eventful birth, but I am just in so much pain. Make it better, please.
Okay. Tell me what have you tried already, Hannah?
Okay, that's a good question. So at the hospital, number one, they told me to feed the baby like whenever the baby was hungry. So I feel like the baby's always hungry. So I'm always feeding the baby. So I'm just like really tired of that. That's number one. But basically they just said, as I just hold the baby, like I've always held babies like this, and it supports their head and then just like bring them close to my chest. And when I do that, the baby just latches on, but it just hurts really bad.
Okay. First, I want to normalize babies are born with a high need to suck. It doesn't mean that they're hungry, but this is just their instinct. They need to suck to help stimulate that breast milk increase in the breast milk.
Okay.
When you are breastfeeding, are you sitting down? Are you on your bed or?
Yeah, I'm usually sitting in a chair. I like it better, because when I'm laying in the bed, I feel like I don't know how to hold the babies. Maybe they're gonna roll off me or something.
Okay. And how does your back feel? Do you feel comfortable? Your feet, your legs? How does
So
it feel?
good, you guys. Yes. That's a good question. I'm comfortable. Yeah, my feet are flat on the floor. Like,
Okay.
I feel like relaxed.
Okay. Do you use any pillows to help support the baby?
Oh, yeah, actually, that would be really nice. Okay, let me see if I'm gonna pretend to get pillows. Okay, I'm gonna get
Okay.
pillows. Oh gosh, that
Okay.
feels so much better. I didn't even realize I was having like pain here.
Okay. Okay. And so you definitely, you're right. You want to bring baby close to you. I'm going to pull my baby out. You definitely want to make sure that your baby is, tummy to tummy,
Okay.
more of a more on like a prone position on your chest. And if you're going to use that cross cradle position, you also want to make sure that you have some support on behind the ears. And with the opposite hand, you are grabbing your breast.
Okay, so if I put
Okay.
my hand here on baby, like that, that's good.
So kind of like this. Oh, let me turn so like this, right?
Oh, okay.
Okay. So then with the opposite hand, you're grabbing your breast. Watch for your baby's reflexes, right? When your nipple goes to the nose, baby's gonna have an instinct to open. You want to make sure baby has a big, wide mouth open before you attempt to latch the baby to the breast. The goal is for most of the breast tissue to be inside the baby's mouth. So maybe all you're seeing is just the areola part that you're seeing is going to be on top of baby's lip.
Okay.
Um,
Should I try now or?
yeah, go ahead.
Okay,
Try.
so I'm gonna pause everybody. Yvette, you're the best. This is going great. I'm gonna pause everybody. So here I am, I'm in this position, right? I'm doing cross cradle. I feel fully supported. Remember, I have pretend pillows. Feel fully supported. I've got baby belly to belly, and
Mhm.
baby is actually ear, shoulder, hip aligned. So we're gonna say Yvette took a look at that. Baby's in alignment. Now I've got the breast in this hand. Who wants to jump in and help me out? Because if I latch baby on like this, I'm 12 hours in, I'm sore. I guarantee you this position, I'm going to be in a bad latch. Who can tell me why? Anybody jump in, guess. It's more fun when you talk.
Your hand position should be in the U shape.
Hand position in the U shape. Okay, so when I have baby in this position, in the C shape, remember, that's like me taking my breast and shaping it this way and trying to take a nice big bite, right? And so in this position, go ahead, Miriam, tell me, how am I supposed to hold my breast? Well, how would you say it? She's like, girl, okay, go take over. She's like, I shouldn't have spoken up.
Bring your hand underneath your breast
Okay,
and you're gonna squeeze, not at the nipple, just around the areola.
okay, like here,
Squeeze it, yes. And you bring baby to the breast
okay.
and tickle his nose to down to the chin.
Now
So
it's
the
very
baby
hard
can
to
have
see. Sweet Miriam, this is very good, Miriam. Okay, ready? I'm gonna come closer. This is where my hand position is on my breast. Help me out. Why am I gonna get a bad latch now?
You are just holding onto the center of the nipple, so there's not enough room for the baby to actually latch wider.
That's right. So how am I gonna fix it, Miriam?
Open up your fingers.
Okay. Now what happens realistically with parents when we do this? Always. This is what always happens. They start here. They always end up here. That's where baby's mouth should be. I'm telling you, this happens every single time, right? So we want to exaggerate it. We're talking about, yes, you want it in a U shape, but what was you don't have to use my words, but these are the ones that have worked best for me. Think about where the underwire of your bra is. Parents start back here, right? And compress. By the time they've compressed, their fingers are about here. Okay. All right. So you want to keep going, Miriam? You were doing great. She's like, no, I don't want to keep going. Why would I want to do that? Now you have to. Okay, ready? So I'm tickling. You said tickle. You said tickle with the nose to the chin, right?
Okay, right.
Okay. So I'm tickling nose to chin. Now what else? What do I do?
Make sure that the baby has that open like
Again. Okay, make sure he's got it open wide, okay? Then what?
and the baby's gonna just latch on. It's while you're squeezing the breast, you make sure it's in there.
Okay, ready? My baby's gonna latch on, you guys. Can you see it? Why am I in pain? Who wants to jump in? Somebody else. Tell me what we missed. Why am I in pain? Ashley?
So you want to hold baby's head where baby is able to, oh, I forgot what you called it. The positioning of baby's head has to be up higher. So making sure that the chin is lifted up.
How do I facilitate that, Ashley? So I'm in this position here. How do I ensure that baby has to lift their head up and come onto the breast, chin to nose?
So put his chin, baby's chin towards your nipple.
Okay, so I'm gonna put baby's chin to the nipple. And now I'm gonna bring baby on the breast.
Too high.
Too high. Try again. You got this. Think about it. I want baby to reach up. So watch what I'm gonna do.
Nipple to nose.
Nose to nipple. Chin in,
Yeah.
baby reaches up.
Yeah.
Okay. So we started off, we're kind of back to basics now. So we've got alignment. Good job, by the way. We've got alignment. We checked mom's alignment. She's comfortable. Oxytocin is flowing. We've got baby's alignment all in one line. Baby's supported, belly to belly, feeling secure. We can't skip the piece of positioning where we line baby nose to nipple. If we don't do that, forget everything you talked about latch. You're not protecting baby's airway. Latch is never going to happen. Okay? So always as you are positioning baby, oh, baby's belly to belly, that's great. It looks like baby's in alignment. Let's see, is baby's nose lined up with your nipple? Huh? What do you mean? Bring baby further over this way, line up nose to nipple so that when baby comes on, they need to reach up, just like they're taking a big bite of a sandwich. They're not gonna bite you, I promise. And putting the breast in their mouth, okay? So never skip that part. So we've got an alignment. Now we've talked about breast shaping. That's the first part of latch. We talked about fingers, walk your fingers back a little bit. I don't know how many times I've said that in my life. Walk your fingers back a little bit, right? We don't want fingers to get in the way of where baby's mouth should be. We want to compress the breast in the direction of baby's mouth. This direction is not going to work. This direction in this position is going to work. Now I'm going to switch positions. You tell me how I'm going to compress my breast, okay? I've just had a C-section. I don't like cross cradle. Don't try me on cross cradle. I'm never going to do it. I'm now doing football position this way, and it's very comfortable for me, except I can't get baby to latch. So how am I going to, what direction am I going to compress my breast? You tell me. So here's my breast, and you're teaching me compression. How am I going to compress my breast? Yvette, you've got a doll. Put your doll in position. Look at baby's mouth, right? Because this is what we're teaching, and we're teaching it online. So you have to figure out a way to, like, you might be able to find out a way to teach it. But how do we figure out parents to teach it? Look at your baby. What direction's baby's mouth going? It's kind of going up and down in this position, right? Yeah, so Yvette's doing it. I could come here. Absolutely. This might be comfortable for me. It might not be. The other position I could come into, what is what, Yvette? All the way underneath again, just like a U, just like this, right? Up. Now, if for some reason baby's coming up this way, which again, I don't really recommend baby's coming up this way so much, but some people do it. We are going to be changing positions. Now, baby's mouth is going like this. The breast also needs to be going like this, okay? All right, so now we figured out breast shaping. We figured out bringing in baby swiftly. What's happening? I'm 12 hours in and I'm in so much pain. And no matter how many times you tell me, bring baby in, I'm not bringing baby in, because when I bring baby in, I'm flinching, which means that I'm hesitating. And that millisecond that I'm hesitating, baby's closing their mouth, and I keep getting bad latch. What are some cheats that I taught you to help baby open their mouth a little bit wider?
Holding the lip open a little bit.
Yeah, okay.
Before.
So in this scenario, I've had 3 children. This is the only one that's given me any trouble with this, but he was also born a little bit small. I'm very used to holding my baby. I'm very used to breast shaping, and here I am, but I just can't seem to bring baby in quick enough. I'm gonna use my forefinger, and I'm just gonna put a little bit of pressure on baby's chin as baby comes in, okay? So here we go, baby. I'm gonna go nose to nipple. Nose to chin. Nose to chin. He opens up wide. I'm going to use my finger, whoop, roll breast in. Oh, that's so much more comfortable. Now that's an extremely advanced move. This is my first baby. No chance at all that I'm going to be able to do anything with my fingers. I need 6 hands just to do the breast and the baby. What can you teach me? My breast is quite pliable, by the way. Does anybody remember? Compress the breast. We're going to point the breast away from baby, right? More towards the nose, away from baby. And as baby comes on, I'm going to bring in baby's shoulder blades so that baby relaxes the head back. I'm going to bring in baby's shoulder blades, and I'm going to roll my breast into baby's mouth. I'm going to use that bottom part of the breast as I compress it. I tilt it up. I'm going to roll it. It's going to put pressure like this and make baby open their mouth. I'm literally going to put more tissue into baby's mouth. Okay? And then what comes next? I now have this latch. Somebody ask me how I'm feeling. I'm nursing baby. Somebody help me out. Ask me how I'm feeling. Lorena, ask me how I'm feeling.
How are you feeling?
Oh my gosh, that feels so much better. I mean, it still hurts a little bit. Is that normal?
Just a little bit pain. Yeah. Let's try it for three times maybe. You wanna go ahead and start all over again and see what happens next?
Okay. You know, I've already achieved this good latch, I think. How do we know? How are we gonna know? Tell me, do you remember what I told you about pain? Who can tell me what I told you about pain? And we're totally over time. Go
The
ahead.
pain that I was gonna be normal, it is just a little bit. But if it's a lot of pain, then that means something is not working out properly.
Yeah, so initially I've been nursing 12 hours in pain. My nipples are really painful. I latch baby on. Oh, it hurts, it hurts. Count to 5. 1, 2, 3, 4, 5. Oh, okay. I'm starting to feel better. Did your pain level drop? What is your pain level now? It's about a 2 or a 3. Oh, okay. Then we know we're not re-damaging the nipple. Well done. And so before we sign off, tell me what are the few things that you're looking for to make sure that baby is latched on now that mom has no pain? Because sometimes bad latch is non-painful. What are the 4 things you're looking for? Someone said it earlier, asymmetrical latch, right? So look at that. You can see more of the areola on the top than on the bottom. What else are we looking for? Is the baby's chin in? Baby's chin is into the breast, yes? We're seeing smooth rhythmic patterns, and that baby has a nice wide open angle. And you've done it, you've fixed it, and I go on to breastfeed for 2 years, and we're so bonded, all because of you. Thank you so much. Okay, that's our training. I'm happy to hang out for questions if anyone can, but I know everyone probably needs to go. Thank you so much for being here. I hope that was helpful.